Welcome to this session. It's the Boxed Warning Toolkit, What Do Derms Need to Know session, and we got a great lineup of speakers. I'm going to be kicking things off talking about the myths versus the science of box warnings. And I think that over the past year or so, the concept of box warnings has become much in the forefront of dermatologists' minds. And so I think it's important, what does this mean? Here are my disclosures, none of which are really relevant to this talk here. So let's start with myths 1 and 2. So boxed warnings are not rooted in federal law. Boxed warnings are issued only after a causal relationship has been established. Well, it turns out boxed warnings are in fact described in the United States Code of Federal Regulations under warnings, 21 CFR 201.57E. And here's what that code says. Labeling shall describe serious adverse reactions and potential safety hazards, limitations in the use imposed by them, and steps that should be taken if they occur. Labeling can be revised to include a warning as soon as there is reasonable evidence of an association of a serious hazard with a drug. A causal relationship need not have been proved. Very important. Special problems, particularly those that can lead to death, serious injury, may be required by the FDA to be placed in a prominently displayed box. The boxed warning ordinarily should be based on clinical data, but animal toxicity data can be used in the absence of clinical data. Okay, myth number 3. A drug with a boxed warning should not be used. Well, let's look at the situations that the FDA actually applies a boxed warning. When the risk of an adverse event is so serious that it can outweigh the benefits of a drug, such as being life-threatening, fatal, or cause permanent disability, that might be a reason to put a boxed warning. When serious adverse events may be prevented or the risk decreased with appropriate prescribing considerations, such as lab monitoring or suitable patient selection, that may lead to a boxed warning. The FDA may approve the drug with a mandatory restriction or guidelines for safe use. And there's other unspecified circumstances where you may want to anticipate an adverse reaction, such as in contraindication of drugs in pregnancy. Now, these are the main situations where the FDA applies a box warning. But what you see here is the FDA is not saying, do not use the drug. They're saying, clinicians, use your common sense, your experience as a clinician, and do what's best for the patient. These warnings are meant to help educate you and your patients on how to best use the drugs. So a boxed warning does not mean do not use the medication. Myth number 4, the FDA application of boxed warnings is decreasing. Well, let's look. Between 1975 and 1999, the FDA approved 548 new drugs. By the year 2000, 45 of these drugs had at least one boxed warning. That's around 8%, a little over 8%. 16 were withdrawn from the market, around 3%. Now, between 1997 and 2009, 219 drugs were approved by the FDA. And by 2016, 30 of those drugs had at least one boxed warning. That's nearly 14%, almost double what happened in the last quarter century of 1975 to 2000, and 11 were withdrawn from the market. That's 5%. That's also an increase over that quarter century. So the use of boxed warnings and withdrawals is actually increasing, not decreasing. Now, here's a paper from JAMA looking at post-market safety events among novel therapeutics between the years 2001 and 2012. So if we focus on the pink box on the right, I'll give you a summary of what it said. So between these years, the FDA approved 222 novel therapeutics. 183 were pharmaceuticals, and 39 were biologics. Now, 129 new post-market safety events occurred. 3 withdrawals, 61 boxed warnings, and 59 safety communications over an average of around 12 years follow-up. This means 32% of all novel therapeutics in that decade had a warning. A safety warning, had some type of safety event. That's 1 in 3 drugs have some form of safety event acknowledged by the FDA. Now, biologics are actually slightly more likely to have a post-marketing safety event. If we look here on the x-axis, we have time since FDA approval in years, and on the y-axis, the novel therapeutics with post-market safety events. And while it doesn't seem to be a huge difference, the biologics tend to have slightly more risk for a post-marketing safety event than pharmaceuticals. Now, dermatology drugs in particular actually are not the most likely drugs to have a post-marketing safety event. We can see here, psychiatry drugs are more likely to have a post-marketing event. But autoimmunity, musculoskeletal, and dermatology therapeutics fall in at number 2. We'll say we're tied with neurology. Myth number 5. Medications with a boxed warning cannot be distributed over the counter. When was the last time you used ibuprofen? So it turns out ibuprofen has a boxed warning for cardiovascular thrombotic events. So nonsteroidal drugs can cause an increased risk for serious cardiovascular thrombotic events, including MI and stroke, which can be fatal. And this risk can occur early in treatment, and it may increase during the duration of use. And we know that NSAIDs also have a box warning for gastrointestinal risks, such as increased risk for bleeding, ulceration, and perforation of the stomach or intestines, which can be fatal. Show of hands, who's used ibuprofen since they've been at South Beach Symposium? Don't lie. Oh, there we go. Hands in the air, I love it. Okay. Myth number 6, dermatologists are inexperienced handling medicines with boxed warnings. In fact, there's over 50 drugs in dermatology that have a boxed warning. And I think that this is a testimony to how good dermatologists are. We use many drugs with boxed warnings, and we do it competently, we do it safely, and we help our patients. So I think this is a testimony to our specialty. So let's walk through a little bit of this. TNF-alpha inhibitors have a boxed warning for serious infection risk and malignancy risk, but we use these routinely for many of our patients, not just in psoriasis. Isotretinoin and retinoids have a boxed warning, in particular for contraindications in pregnancy. I don't want to leave out the cosmetic folks, right? Botulinum toxins have a boxed warning. Did you know that? And for the medical people, how many of you inject Botox for hyperhidrosis? Show hands. Yes. I do too. And you know what? I don't recall advising my patients about a boxed warning when I treat them for hyperhidrosis. Maybe that's something I need to do. But botulinum toxins have potential life-threatening distant spread of toxin effect after local injection. Interesting. Antimicrobials, some of them have boxed warnings. So for example, clindamycin has a warning for C. diff infection, Cipro for risk of tendon rupture, and some of the others that we use. Like we probably don't use too much oral ketoconazole, but we do for oral itraconazole, and those can have contraindications for congestive heart failure, and the ketoconazole for hepatotoxicity risk. And then immunosuppressives. So for example, methotrexate, mycophenolate, azathioprine, cyclosporin all have different box warnings for things such as being immunosuppressant, use in pregnancy, infection risk, malignancy risk. So that leads us to the JAK inhibitors, because really what's driven this interest in box warning over the past, say, year has been the fact that the JAK inhibitors have received a box warning, more or less a class effect. So what is actually in the box warning? Well, risk for infection, death, cancer, cardiac, and clotting. So let's, myth 7. JAK inhibitors are more dangerous on average compared to commonly used immunosuppressive therapies. So I just recently published, along with Stefano Daniele, in December, an article, as you can see here in the JDD, titled JAK Inhibitor Safety Compared to Traditional Systemic Immunosuppressive Therapies. And the driver behind this paper was, 6-7 years ago, you were considered a phenomenal dermatologist if you treated your atopic dermatitis patients that were moderate to severe with methotrexate, cyclosporin, or oral steroids, and they got better. You were a great dermatologist. Yeah, I see someone nodding out there. But were we? Let's see what the data shows. So what we did in this study is we just simply took the adverse events characterized by events per 100 patient years for upadacitinib, 2 doses, and abrocitinib, 2 doses, and compared it to methotrexate, cyclosporin, and systemic corticosteroids for 4 major adverse events: the malignancy excluding non-melanoma skin cancer, non-melanoma skin cancer itself, major adverse cardiac events, and then VTE. And what we found in the red numbers at the bottom is that on average, the methotrexate, the cyclosporin, and the systemic steroids tended to have higher rates of adverse events than all of these JAK inhibitors, regardless of the dose. And look at the systemic steroids. It's off the chart. So what does the current long-term upadacitinib data reveal? So upadacitinib studies range from age 12 to 75, and they involve patients with everyday comorbidities. A lot of us think that in these studies they excluded anyone that may have actually been at risk for any of these boxed warning events. But that's not true. In these studies, 50% or more of the patients had more than one cardiovascular risk factor. 30% of patients were current or former tobacco or nicotine users. 20% were women on OCPs, and 15% of patients were older than 50 with one or more cardiovascular risk factors. Around 19% had a BMI greater than 30. This sounds like the average American population to me. This isn't a cherry-picked group of people. And so what these 3-year safety, so this is 3-year safety data from the phase 3 clinical trials. You can find this on the AbbVie website. And what we see in the bottom is a published scientific article recently about the safety of JAK inhibitor across 15,000 patient years. But on the right, what we're seeing here are events per 100 patient years. You have in green the all patients for 2 doses of upadacitinib, and on the right in blue, adolescents. And you can see all these different side effects listed on the left and the adverse event rates. And I'll just bring your attention down to, so if you look at active tuberculosis, less than 0.1 across the board, 0 in adolescents. If you look at gastrointestinal perforations, that's 0 across the board. You look at lymphoma for the low doses, it's basically 0 across the board other than all patients, 30 milligrams daily. There's a less than 0.1 events per 100 patient years. And then you look at MACE, venous thromboembolism, again, in the all patients, less than 0.1 events per 100 patient years. In adolescents, it's 0. Now, with this adolescence, I don't want to leave out abrocitinib because something happened while we're here at the South Beach Symposium. Abrocitinib was just approved down to age 12. So now both upadacitinib and abrocitinib are approved down to age 12. Why? Look at the adolescent data. This data from upadacitinib is on par with abrocitinib for adolescents. But what this speaks towards is safety. So what we did in our paper in the JDD here is we actually took, in this bullseye diagram, whatever you want to call it, in the middle is your reference. That's the healthy population. And we looked at the 4 different major adverse events and the event rates per 100 patient years. And then in the second tier of the circle are the moderate to severe atopic dermatitis patients and their event rates. And then in the outside, the event rates per 100 patient years for the JAK inhibitors, in particular Abro and UPA. And what I show here in red are updated numbers from this long-term safety with the JAK inhibitors, in particular the upadacitinib data. And we can see here that, for example, in the lower left, in the green, the major adverse cardiac events, the average American population, it's 0.14 events per 100 patient years. For moderate to severe atopic dermatitis, it's 0.63. But for the JAK inhibitors, it's lower. And look at UPA, 0.09 and 0.03 based on the long-term data. And then if you look one over, the actual rate of VTE, again, lower than the normal population, lower than moderate to severe AD baseline. So actually, the JAK inhibitors in these particular adverse events seem to be helpful for patients. So myth number 8, oral corticosteroids, prednisone, have a boxed warning. They do not have a boxed warning, but I just showed you data. They have some of the worst adverse event rates of all of the therapies we've been talking about. So in this particular study, this was a study that was looking at adverse event or venous thromboembolism among atopic dermatitis patients. But in their statistics, what it said was that around 46% of all AD patients have received oral systemic steroids. And around 75% of all moderate to severe AD patients have received systemic steroids. So systemic prednisone or oral prednisone does not have a boxed warning. It has some of the worst adverse events, yet dermatologists and non-dermatologists, 75% of all moderate to severe AD patients are getting them or have had them. It makes us want to rethink the order in which we use medicines in atopic dermatitis. And lastly, myth 9, dermatologists should be afraid of medicines that have a boxed warning. No, we don't need to be afraid of it. We've been doing it competently for the last 30 years. What we need to do is understand the medicines, use shared decision-making with our patients, educate them about the risks, but we don't have to be afraid because the knowledge that we're learning from these medicines is that we can use them safely in the right patient population. And with that being said, I think we're ready to introduce our next speaker, Leon Kursick, who's going to now tell us when not to prescribe. Thank you.
Thanks, Chris. Actually, it's going to be a little bit more complicated than not to prescribe. It's going to be similar to what Dr. Bunig talked about, but it's a much less sophisticated level. His lecture was so sophisticated and scientific. Mine is going to be a little bit less scientific and more fun. So, I didn't go to Yale, so I went to Downstate in Brooklyn. This is my conflict of interest statement. It hasn't changed since this morning. So, when not to prescribe or when to prescribe, right? So if I show you this drug may cause an increased risk of serious cardiovascular thrombotic events, MI, and stroke, which can be fatal. Fatal. It can cause perforation, bleeding, ulceration of the intestines, stomach. It can be fatal. Renal effects of the drug. It can cause papillary necrosis, renal injury. Liver. It can cause fulminant hepatitis, fatal outcomes. Fatal outcomes. Aseptic meningitis, fever, coma. So, what biologics package insert is this? A, etanercept, B, secukinumab, C, ustekinumab, D, tildrakizumab. E, none of the above. Actually, you would know the answer if you were paying attention to what Chris was saying. It's Motrin suspension, which my wife feeds my kids all the time. So, if you read a package insert, you probably will not prescribe any drug. So, I sort of disagree with Chris when he said that we're experts in dermatology, managing warnings and package inserts. We're really not. That's what Seinfeld thinks that that's why they call us pimple poppers. Because those drugs we don't prescribe, still today, 80% of the biologics are prescribed only 20% of all the dermatologists that we have. And the JAK inhibitors, unfortunately, even though they are great drugs, they are still being not prescribed as much as they could have been. There are so many candidates for these drugs that unfortunately we do not prescribe. So why is that? So couple of myths. Psoriasis, and I'm going to concentrate on the biologics for psoriasis, but this can be extrapolated to any drug with a heavy package insert, what I call. Psoriasis treatment causes depression. Is that myth or truth? It's really a myth, and this comes from the drug, brodalumab, which is Silic, that requires a REM because of the depression, because during the study, 4 people jumped off the window and killed themselves. And unfortunately, the agency put this REM requirement that is it the drug or is it really the disease? So 16.5% of the patients with psoriasis met criteria for diagnosis of major depression. This is without the drug, just regular psoriasis patients, right? So really, box warning for suicidal attempt or suicide, is that really deserved or not? But it doesn't matter if it's deserved or not. It's FDA's job to tell us about those things that happens during the studies. They have to tell us even the things that happened on the placebo group during the studies. It gets to the package insert. And I'll give you an example for that. But actually, they clearly say a causal association between treatment with Silic and increased risk of suicidal ideation and behavior has not been established. Despite that, it's in the package insert. So, actually, if you look at the studies, and I was part of those studies a long time ago, it was done originally by Amgen, then the drug was sold to Valiant and Ortho now. But if you look at the anxiety subscale and depression subscale, actually people on the drug did statistically significantly better than the people on the placebo. Their depression, their anxiety all got improved on the drug during the study. Despite that, you saw the package insert and the warning site that required the REMS, right? This is very interesting. This is Otezla package insert, right? One of the most benign drugs. And guess what happened? In the clinical trials, 2 patients who received placebo committed suicide compared to non-in-Otezla treated patients. Despite that, we have a warning for depression in Otezla package insert. You go and figure out the government. You cannot. So when we look at serious adverse events, it's called the FEARS data, FDA Adverse Event Reporting System. Depression for every biologic in this country since the biologic started to 2018, you see that most of them do have something, suicide attempt completely. Actually, most of the common ones is 115 is adalimumab, right? Completed suicide. Now, where those people knew what they were doing and they really killed themselves and the other 68 didn't know, who knows? But the bottom line is there is in every drug, and not because of the drug, it's because of the disease itself. When you go through the EMEA data, the European data, similarly you see similar things. In this case, the most was infliximab, probably because infliximab is being used much more than there than here, right? So when you look at the mental disorders in patients with skin diseases, this is April Armstrong. She's a great number cruncher. I call her a number cruncher. She does a really good job on that. And when you look at those numbers, actually you see that IL-17 levels, which is the major player in psoriasis, right, higher in activated T cells among those patients who have depression or anxiety. So you looked at the neurological system, actually there is IL-17 and Th17 cells found more in the neurologic system of those patients. And the bottom line is those patients are more prone to have depression or commit suicide than the regular population. Now, in the old days, we used to say, well, because their skin looks bad, they are depressed because of their disease. Actually, that's probably true, but pathophysiologically, they also have factors that causes depression naturally in those patients, not because they look bad, not because they cannot wear short sleeve, not because they cannot go to beach because they look bad. It just they are systematically, inherently have these factors, the cytokines that cause depression. And this is from Denmark. There are some advantages of, I guess, having a nationalized healthcare system. They record everything, especially in a small country like that, where there is 17 million people. So when you look at those, they actually have, they see that the patients with psoriasis have high risk of bipolar disorder. They have high risk of cognitive disorders. So immune dysregulation has been suggested to play a pivotal role in schizophrenia. So the bottom line is they are inherently more prone to have mental disease. Same thing in South Korea. So is it the disease or is it the drug? This is a publication that I had at JDD. Basically, it's really not the drug, it's the disease that causes depression. So is it fair that all those drugs that with warnings for depression, suicide, that they get that box warning? So it's up to us as providers to judge that package insert and use it accordingly as we understand, not the way that the government tells us. So, next myth or truth, biologics cause cancer. So there was a really nice study a while ago from Europe, actually not all Europe, from Israel, Italy, Spain, United Kingdom, and Republic of Ireland. Those are all the countries where there is actually nationalized healthcare system that things get recorded much better than they get recorded here. And they looked at exposure to biologics to a match and sex-aged population, to the psoriasis patients and who were on biologics, and basically when they looked at the adjusted odds, there is absolutely no relationship between cancer and biologics. There was a very nice study from tildrakizumab from Sun Pharma that they looked at 5 years safety with tildrakizumab itself and in relationship to malignancies, no signals. Next, only TNF-alpha inhibitors are safe. So I give a lot of lectures, I talk to people, and everybody says, we feel so much comfortable with TNF-alpha inhibitors. Why? Well, because we feel it's safe. Is it? This is actually Humira package insert, 101 pages. Guess what? This is ixekizumab package insert, 25 pages. Secukinumab package insert, 19 pages. Tildra, IL-23, 11 pages. So the new drugs, I think they are much safer and much more effective. But it's all about perception. It's the optics, right? We feel much more comfortable with Humira. We've been using it, and really it's safe enough, and it works well enough. But again, when you look at the package insert, it's scary. And this is true, by the way, all TNF-alpha inhibitors, not only Humira. But I just gave you that as an example. It is the most commonly used biologic in the world. So how are we treating those patients? As I mentioned, actually MPF wants us to go all the way down to 1% body surface area, right? And if you don't get 1% body surface, area, change it to another medicine. We have so much available. So in conclusion, either we can practice medicine like my grandmother's telephone, right? And that's like methotrexate, cyclosporin. Or we can practice medicine with the old biologics, the flip phone that sometimes I still use. Or we can come to this century and use some iPhone and use the new biologics, right? So it all depends on how we practice. Unfortunately, still, some of us are still here, and some of us are still back here. And when you look at the prescriptions, that's what we see, unfortunately. So how are you going to treat this patient? Hopefully systemically, not with a bunch of creams. So hopefully after this lecture, nobody is afraid of big bad biologics, because people are. I thank you so much for your attention. If you have any questions, I'll be more than happy to answer, or you can write to me at viduderm@yahoo.com. Sure.
Thank you, Leon, for that. It was wonderful. Now I'm going to introduce Bill Damsky. He's going to talk about what happens when. So Bill is coming from Yale. He's one of my colleagues there, and someone who has been doing a lot of research into JAK inhibitors.
Hi, everybody. Thank you, Dr. Bunik, for the invitation to speak today. So my talk is entitled, What Happens When? These are my disclosures. I will briefly discuss off-label use of JAK inhibitors. So just to set the stage, this has probably been set a number of times at this conference, but we have a number of approved JAK inhibitors, which I'm going to focus on today. You can see the different drugs here. The indications, the approved indications that are in red are dermatologic indications, which are of particular interest to us. And there are 4 JAK proteins, JAK1, 2, 3, and TYK2. And depending on which JAK inhibitor you're using, you may inhibit one of these proteins, you may inhibit many of these proteins. And so you can see those different specificities represented here. So what happens when I prescribe a JAK inhibitor? And really, I think one of the most pivotal or important things to think about is, how do I discuss the safety data with our patients? Well, first we really need to understand, what are the box warnings and where do they come from? So here are the box warnings. Again, this has been shown a number of times at the meeting: serious infections, mortality, malignancies, major adverse cardiovascular events, thrombosis. So these are pretty scary side effects from a patient point of view. Importantly, these box warnings are considered a class warning. So these are on all available JAK inhibitors in the US for inflammatory indications, both topical and oral. So even the ruxolitinib cream gets these black box warnings. Recently, we found out that deucravacitinib, which is an allosteric inhibitor of TYK2, did not get these warnings, although there is still some information about these side effects in the package insert. So it's really important to understand when we're going to discuss this with patients, where did these data come from, and what do they mean for the patients that we're treating? And Brett King earlier in the day talked about this New England Journal paper, which was a study that was required by the FDA as a part of the tofacitinib approval process. And really was based on the observation that there was an increased incidence of hyperlipidemia and cancers in patients during development during the RA studies. So this was a randomized, open-label, non-inferiority, post-authorization safety endpoint trial. Much easier to say the oral surveillance trial. And this was rheumatoid arthritis patients. And really, this is where all the box warnings for JAK inhibitors come from, is this study. And so this was a huge study. And so there were about 1,500 patients with RA treated with tofacitinib 5 milligrams twice daily, about 1,500 patients with RA treated with tofacitinib 10 milligrams twice daily, and patients treated with a TNF-alpha inhibitor, again, about 1,500 patients. This included either adalimumab or etanercept. There were two co-primary endpoints from this study. One was major adverse cardiovascular events, and the others were malignancies, excluding non-melanoma skin cancers, which of course are still of interest to us, and I'll talk about that a little bit later. And how this study was set up is that the non-inferiority definition was designed as a hazard ratio that had a confidence interval that crossed, the 95% confidence interval that crossed greater than 1.8 when comparing tofacitinib, both groups combined, to the TNF-alpha inhibitors. Again, this was a huge study, greater than 300 sites in 20 countries, and the median follow-up was 4 years. So let's take a look at these patients. Again, these are all RA patients. They have active RA despite methotrexate. During this study, background methotrexate was almost universally continued in patients, and so we need to remember these are patients that are not only taking a JAK inhibitor, they're also taking methotrexate. Further, about 50% of the patients were also taking prednisone. In the way that the study was designed, the patients were 50 years of age or older and had at least one additional cardiovascular risk factor. Here's how they were defined: either a current cigarette smoker, history of hypertension, history of low HDL cholesterol, diabetes, family history of premature coronary artery disease, extra-articular RA, and or a history of coronary artery disease. Although it wasn't actually a formal inclusion criteria, the BMI of these patients tended to be relatively higher. You can see that the median age of patients was about 60 or 61 years of age, mostly females, mostly white, and actually a fairly high degree of either former or present smokers. Looking through this paper, I couldn't actually find how many patients that were enrolled were current smokers. And so let's look at major adverse cardiovascular events. And so the MACE definition in this study was death from cardiovascular causes, non-fatal MI, or non-fatal stroke. And when we look at tofacitinib versus TNF-alpha inhibitors, and I've drawn in here what they defined as the non-inferiority limit here at 1.8, and we can see that the tofacitinib 5 milligrams and 10 milligram group both cross that interval, and so it actually is inferior in terms of these outcomes compared to a TNF-alpha inhibitor. When we drill down on these data a little bit more, again, this is a subgroup analysis, but when we look, the vast majority of patients that are actually having these adverse events are patients that are greater than 65 years of age. And if we're looking at patients less than 65 years of age, there's actually really not that much of a difference, and it's certainly not significant. But it does look like there's a trend in that direction. Well, what about malignancy? Again, we're looking at this the same exact way. Here's their non-inferiority threshold. If we're crossing this, then we're actually inferior, and so it looks like there is an increased risk of malignancy the way that this study was designed. Again, you can see here the numbers that I've outlined for you. Most commonly was lung cancer. Again, we don't know about smoking history or current smoking status in these patients, but at least 50% were former smokers or current smokers. And when we look at the incidence by age, we can see that, again, the vast majority of the malignancies are coming in patients greater than 65 years of age. And while there is a trend towards increased significance in patients that are less than 65 years of age, it's less profound. And I think that there actually is some mechanistic data that suggests that really JAK inhibition could suppress anti-cancer immune responses. And so I think this probably is a real effect. We can see other side effects that are also on the label, including DVT, PE, and all death from any cause. But really the generalizability of these data have been called into question. I think this is a theme that's been presented here as well as in other dermatologic conferences for good reason. The RA study includes patients that are older. They have many medical comorbidities, and they may not reflect patients in dermatology which we're using JAK inhibitors to treat, which may be younger and may not have quite so many medical comorbidities. I think a really important point here too is that these patients were also taking methotrexate, and a lot of them were also taking prednisone. So we're not only studying the effect of tofacitinib, we're studying the effect of tofacitinib plus methotrexate, and oftentimes plus oral prednisone. And so if we're thinking about designing a scientific study, it's probably not the best study design because it's really a confounding factor. And for most of our dermatologic patients, they probably will not be taking these medications as well, certainly probably not both of them. These patients are rheumatoid arthritis patients, and so there is some intrinsic hypercoagulability, which is a side effect that a lot of people have concerned about, rightfully so. And so that's important to recognize as well. Also, this is a study that was done with an older JAK inhibitor, tofacitinib, and so we certainly have newer, more selective JAK inhibitors, which so far have not shown these safety signals. We'll have to wait and see. Again, it's important to point out that during the original RA studies with tofacitinib, we also didn't see these signals, and it was only these really long-term studies that did reveal this data. So here's what we know, and this is where it comes down to how we counsel our patients. So in a patient that has rheumatoid arthritis, which again, these are the study patients that led to these black box warnings. If you're a patient with rheumatoid arthritis, there are so many drugs to treat rheumatoid arthritis, you probably wouldn't actually want to go with a JAK inhibitor when you had other options. We don't know how these patients compare to patients with rheumatoid arthritis that were not treated. So we don't know how this really modifies the natural history of the disease. Maybe the patients even treated with a JAK inhibitor do much better than those patients that were not treated, potentially including long-term cardiovascular events. And really, in its relevance to dermatology, what we don't know is when we're using these medications to treat diseases that we don't have other FDA-approved therapies for, patients are going to be suffering without real improvement. Where does this fit in? Again, the data that we do have through the clinical studies that have been done in dermatologic interventions suggests that there's not a real significant signal for these things. But we can imagine that when we're comparing a patient that has a really significant skin problem that's not getting treated, has a lot of inflammation, versus a treatment that might not work, which might partially suppress this inflammation, versus someone with atopic dermatitis or alopecia areata that's actually very happy. We don't really know how their long-term outcomes compare quite yet. So I like this to include this slide because I think it really summarizes kind of what we do know and what we don't know. And so it all comes back to this question of how do we counsel our patients, and I'll wrap up because I know I'm just about out of time. How do I discuss the risks with them? Well, this is my personal opinion, but I think patients really look to us to guide them through this therapeutic decision-making process. And we're not recommending one treatment over another. We're really presenting the facts. We're presenting our experience as a physician, and we're trying to help the patient, make this very complex decision. And so the way that I tend to present this to patients is, I think you would be a good candidate for this medicine because you're less than 65 years old. Maybe they're not, and again, obviously they may not qualify for all these criteria. You've never had a blood clot, you don't smoke, you don't have an advanced cancer, you don't have a history of cardiac disease, and really I see how much you're suffering from your skin problem. I think what can be really detrimental to this conversation is suggesting these medicines and going through the black box warnings, which I always do with my patients, but really presenting it as, well, here are the risks, well, what do you think? I think it's a really challenging position for patients to be put in, and I really just don't think they know what to do with this data. And so this is kind of the framework within how I try to present this to my patients. I'm going to kind of skip through these last couple slides just in the interest of time. My main research interest is in the application of JAK inhibitors and other targeted therapies, not to atopic dermatitis or psoriasis or other diseases for that matter, which are common, but to rarer skin disorders. And so in particular, I study granulomatous diseases, and we've had a tremendous amount of luck using off-label treatment of tofacitinib to treat patients with sarcoidosis. Here's a couple examples of improvement in the skin, really dramatic improvement in internal organ involvement shown by PET-CT, and another patient that had really dramatic improvement in the skin. We also use this to treat generalized granuloma annulare and just have had some really remarkable responses to patients. Patients with persistent erythema multiforme, and even patients with oral erosive lichen planus. And so I hope to leave you with the fact that this is an incredibly powerful class of medicines, and when used correctly, JAK inhibitors can allow you to help your patients in potentially life-changing ways. It's important to kind of go through the process of how you're going to counsel patients in your own mind, and help guide them through that shared decision-making process about whether these therapies are right for them or not. And of course, follow the screening and monitoring parameters. And so with that, I'll wrap up, and thank you.
All right, thank you, Bill. All right, so our final speaker in this session is going to be Andrew Alexis, and he's going to talk about how to address patient concerns. We've heard a little bit about shared decision-making and communicating with patients, and in the end, when we're talking with patients, it's a person to a person. So we'll hear what Andrew has to say. And then please think of questions, because we're going to have some time for a question and answer session.
All right, good afternoon, everyone. So this talk, there's going to be a lot of overlap with Dr. Dansky's great talk you've just heard. And so what I'm going to do is just give my approach to some of the key questions. What does that conversation look like in the office when we present a JAK inhibitor as an option? Here are my disclosures. So on the one hand, we are very fortunate to have these wonderful treatment options, newer treatment options for treating multiple disease states in dermatology with our newer JAK inhibitors, including topical, oral, for conditions like AD and alopecia areata and vitiligo, as far as the topical JAK inhibitor is concerned. But then, once we get to this part, to the safety part that we have to communicate to our patients, this is where things can get a little tough in the office. How do you articulate this without just leaving the patient terrified and wondering, why would you even prescribe something like this to me with those scary warnings? And I think Dr. Dansky did a wonderful job explaining the context of the warnings, and that's step one. What I do in the office is I try to give them an understanding of the why. Why is there this box warning, and where did it come from? And I'll explain very briefly the study done with a different medication in the same category in a different disease state, rheumatoid arthritis, in a patient population that was older, 50 years of age and older, who were on methotrexate, and if I didn't say it already, had at least one cardiovascular risk factor. So explaining that this is a different context, that these warnings came from a specific study using another drug in the class in a different patient population that has higher risks. And so that when you're faced with that 25-year-old with atopic dermatitis and you're talking about maybe starting him or her on a oral JAK inhibitor, they can quickly understand that, oh, okay, that sounds like a population that's a lot different than me. Now, that doesn't mean that we have to throw out the black box warning and be cavalier and not be cautious about the safety warnings, but it just at least puts it into the right context as far as risk stratification. And when the patient, it doesn't belong to a specific high-risk group, calling that out to the patient, saying, you know, you're 27 years old, you're not over 50, you don't smoke, you don't have any personal or family history of malignancy or risk factors for cardiovascular and thromboembolic events. So you're someone that I think would be a good candidate for this. That being said, we're still going to monitor you and do the appropriate blood work and follow-up. But when you think about the context of risk, when you think about risk in different patient populations, it differs. And this is just one example, a study looking at the different rates of venous thromboembolism for patients receiving baricitinib across different disease states. And again, you see that for the two dermatologic conditions in the middle, atopic dermatitis and alopecia areata, in this particular analysis, we see much lower incidence rates of venous thromboembolism. So again, conveying to the patient that risks they vary by population, and really trying to make it specific to them. Once again, it doesn't mean you throw the warnings out the window. You know, we're still going to be vigilant and do our appropriate baseline and ongoing monitoring as appropriate, and assure the patient that you'll do that. And then at the end of all this, usually the patient is comfortable understanding that you've thought it through, you've walked them through it that's in a way that's very specific to them, and that after thinking, going through all of those steps, you think that they're a good candidate for the drug that you're talking about. And usually that they can move forward with confidence after that. Other questions that come up once we get over that big safety hurdle is, well, is this going to work? And this is an easier question to answer because for the most part, especially when treating atopic dermatitis, let's say, with our oral JAK inhibitors, we can really show that with the data that we have, that it's quite likely our patient's going to see rapid improvement in itch. Maybe they'll notice within days a major difference, and close following that, they'll see improvements in the visible signs of atopic dermatitis in the weeks that follow. So we can be pretty optimistic about the effectiveness and the speed of response. For alopecia areata, severe alopecia areata, we can also show them good results from the available data, which really there's really nothing else that, in my opinion, that matches the efficacy of what we've seen with oral baricitinib in these cases. As far as other options that they have, I like to present to patients a portfolio of different options that are suitable to them. So you're not just going to give every single option in the whole world, but after considering that patient, their severity, how much the condition is impacting their quality of life, and looking at their specific safety profile, you narrow it down to certain classes of therapies that are appropriate for them, whether it's injectable biologics, phototherapy, topicals, depending on the patient and the disease state, and then offer the pros and cons of each. I'll often just, to help them get a visual, I'll turn the monitor around and show them even not just before and afters from the websites of the individual medicines I'm talking about. I might even show them a graph. I mean, they can see the difference between a treatment line that's way above the placebo line, and you can convey it to them in a way they understand. Then comes the question, well, how long do I have to be on this treatment? Am I going to have to be on this forever? And the nice thing about the response to this question when it comes to oral JAK inhibitors, at least in the context of atopic dermatitis, the option exists for being on it for a period of time and then discontinuing and then restarting without concerns about causing autoantibodies as we would with a biologic. With severe alopecia areata, there's the concern of certainly no patient wants to be on a roller coaster ride of growing hair and then losing hair. So that patient may be less likely to discontinue, but that's going to be a case-by-case basis. But at least offering to the patient that it's going to be an individual decision after observing their response over time. And that also gives them some comfort that this is something that there is some degree of flexibility. So I think that when it comes to our dialogue with our patients for starting a JAK inhibitor, this is a great example of this term that we use a lot nowadays, shared decision making, and this is truly an example of shared decision making. And once presenting all the information in a individualized and nuanced manner that takes into account the context of that specific patient, you can have the patient can make an informed decision, and you can move forward and have a happy patient and an ongoing good relationship with that patient. So thank you very much, and I think we have time for questions.
We have several minutes for some questions, so if you could please come to the microphone and ask questions. I'm going to start one off. Leon, is it possible to get a box warning removed from a drug?
The answer is yes. Actually, in Canada, Health Canada removed the labeling, the warning for the topical calcineurin inhibitors. So Elidel and tacrolimus now don't have the same label anymore as in US.
Just want to know, how would you handle a young woman who's on birth control pills and you want to put her on a JAK medicine? How would you prevent the clots?
Well, if the young woman has a history of smoking and oral contraceptives, I would be very, very cautious to start her on JAK inhibitors.
I'm just saying hypothetically, like if a woman had, terrible severe alopecia areata and was...
Okay, that's different. Now, when we discuss different disease states, with alopecia areata, I don't have much choice, right? That's actually, baricitinib is the only FDA-approved drug for this condition. So I would be much more willing to start that person on a JAK inhibitor versus a woman with an AD, a young woman on oral contraceptives with smoking history on AD, because I have other options.
But if the woman who's going to take baricitinib is on a birth control pill, would you take her off the birth control pill?
I would actually try, for example, Depo-Provera injections that I would avoid the birth control pill itself. But there are other techniques of birth control, right?
Yeah. Now, the other thing, I've seen 2 patients die from biologics. One was a man who had parapsoriasis on plaque that I sent him to an academic center because I really thought he was going on to lymphoma, and the biopsies didn't prove it. Well, they thought he had psoriasis, so they put him on Enbrel. 4 months later, he died of lymphoma, and that was, a shocker. But he was an alcoholic. And so I've learned that I think if you're putting anybody on any of these drugs, biologics, JAKs, whatever it is, take them off alcohol. Make sure they're not drinking. You don't want to lower their immune mechanisms.
Absolutely, but you think they will listen? I mean, it's so hard. But I agree with you 100%. And we have a bunch of people in the old days on methotrexate, right, with alcohol. Before the biologics, I had a bunch of people on methotrexate, unfortunately, and tried to help them to stop the drinking. But as you know, most of our psoriasis patients, unlike the RA patients, they are alcoholic and they have the liver damage already.
No, it's dangerous. Then I had another man who was a terrible atopic all his life, had squamous cell carcinomas, got rid of the squamous cell carcinomas, got rid of the eczema, took care of him from age 48 to age 60, and then Dupixent came out, and he decided he wanted Dupixent, so he went to another doctor. 4 years later, he died of skin cancer. So, I mean, it's risky business when someone's an alcoholic, skin cancer, eczema, and they don't stop drinking, and you're putting them on these drugs because you don't want to kill people.
Look, absolutely. Unfortunately, we practice defensive medicine in this country, and you're absolutely 100% correct. And there is a reason what I said, that only 20% of all derms are writing the 80% of all the biologics, because it takes a lot more attention a lot more time and effort to spend with these patients with no revenue return, to be honest with you.
Now, with JAK inhibitors, though, will you put them on aspirin every time they take it, or low-dose aspirin every other day?
No, you don't have to be. They don't have to be on the aspirin. No,
Not at all. Okay.
no.
Thank you.
So I have a couple questions. I practice in Philadelphia, a very litigious city. And one question is, are you more likely to be sued if a drug has a black box or a box warning and a patient has an adverse event? Is there any data on lawsuits?
I don't know the legalities, but it always makes sense that the lawyer is going to say, hey, doctor, did you read that package insert? That's the first thing they say when you're on the, in the court, right?
I think that one question for the audience is how many people actually read the product inserts when new medicines come out? I think one of the things throughout medical school and even residency training was there wasn't an emphasis on, hey, did you read this insert before you prescribed it? I don't think that a lot of universities are teaching to read the product information because it's dense. You look it up, and as we said, one of them is 101 pages or over 100 pages. But are we teaching young clinicians to actually pay attention to the really important information that's in these labels?
But Chris, guess what? The first thing when you go to Walgreens or CVS, the pharmacist, do you have any questions for the pharmacist? And then if you say yes, God forbid you're going to be there for half an hour until he or she finishes, gives you the whole skip, right?
I had another question, if I may. In terms of vaccination for zoster, I believe they changed the guidelines now, or anybody over 18, I think, can receive the vaccine if they're going to be immunosuppressed. Is that correct? And then what do you do with your patients? Do you insist that they get vaccinated? Do you recommend it for JAK?
I highly recommend them.
Recommended, but not mandatory. I mean, recommended. Can't force them.
And if I can have one more, I do a lot of speaking on these drugs, and I occasionally encounter older dermatologists primarily who object to a new drug, and they'll bring up Raptiva, and they'll say, Raptiva, we thought it was safe, and then it got pulled from the market, and so I'm not going to write a new drug until it's been out for 2 years or 5 years. Two questions there. How do you address that, and do you think that drug should have been taken off the market?
So I told them that I had more than 100 people on Raptiva, and it was a great drug if you know how you used and how to manage those. And the drug was taken off the market really because it wasn't making money for Genentech, and then Roche bought Genentech, and they didn't want to deal with it. There were 3 deaths, and I'm very familiar and close to those deaths, so that's where I'm going to stop.